Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day again. I am Dr. Kurt Orlandias Perez. GS1, GS2, GS3, those are the terms we commonly use or we commonly hear in the hospital when referred to surgical subspecialties, alright? So how do you remember it, or how I remember it is GS3, number 3. It rhymes with the word tree or puno. As if you would remember your anatomy, this is how the biliary system looks like, diba? Here is where your pancreas would be. It is connected to your common bile duct, diba? And your hepatic ducts, as well as to your cystic duct or in your gallbladder, diba? And grossly, para siyang puno, para siyang tree, okay? And this is the main trunk, and then it would branch out inside the liver. So that's why I remember it. GS3 is parang GS3, okay? And also, if you want to be technical about it, with GS3, it involves 3 organ systems, diba? Your liver, your pancreas, and then, although not a discrete or a separate organ system, yung third part now would be your biliary tree or your biliary system, okay? So enough again with the introductions. Let's go straight away to the first organ, which is the liver. So the first organ we'll be discussing today under GS3 would be the liver. This is the liver. In the next slides, I'll be reviewing some of relevant anatomy and physiology to guide us along or to ease you into the discussion. So the liver can be divided into right and left hepatic lobes. Furthermore, the liver can be divided into 8 segments, from 1 to 8. The left lobe is comprised of your segments 1 to 4A and 4B. It's worth noting that the fourth segment is further subdivided into 4A and 4B, whereas the right side of the liver is composed of segments 5, 6, 7, 8. The knowledge on your liver segments is particularly important, especially in hepatic masses that are local in nature. Because, for example, the mass is just in the segment 7 or just in segment 8, you just have to take out that segment of the liver, and then you're good and you're fine. Okay? It will guide us along with the resections as we discuss it later on. So I'm sure it's now you remember how it's being numbered because it's right in front of you. But in med school, I'm sure they taught you about this one, or using your right hand as a guide to memorize the hepatic segments. So using your right hand, make a fist, alright? It is better this way because it will give you a 3D representation of how it is actually situated inside your abdomen. So with your right hand, if you would see, your thumb would correspond to the first liver segment or segment number 1. Its position, it's posterior, and it's on the left side, alright? 2 and 3, okay, on the leftmost. 4A and 4B, with 4A sa taas, or more superior, and then 4B is the more inferior portion, inferior segment. And then 5, 6, 7, 8, para siya nag-go around in a clockwise manner. 5, 6, 7, 8. Alright, so I hope this will guide you along when you assist or when your consultant asks you about liver segments. It's also important when you start reading already CT scans also. This would help you be oriented with your position or liver segments based on the images. As a review also, this is the blood supply of your liver, with arteries comprised, of course, of your hepatic artery, and then medyo mas nakakalito because the artery is actually a vein. It's the liver, its arterial supply comes majority from the portal vein circulation, as much as 75%, whereas its venous drainage is composed of your right, middle, and left hepatic veins, and of course, drainage to the inferior vena cava. More than the arterial and the venous supply, there's a third canal system in the liver that we call the biliary duct system. It's responsible for what we call biliary drainage, or kung saan napupunta yung bile natin that is used for digestion. So this is a review of your biliary drainage system. You have your bile canal pili, this one, okay, and then it goes to your intrahepatic ducts. It goes to the common hepatic ducts, where it is being joined by your cystic duct to form the common bile duct. And eventually, mapaprogress yan, diba, to join with the pancreatic system to drain into your ampulla of Vater. The function of your liver can be subdivided into 2 main categories, namely synthetic and metabolic. Synthetic, it means the liver is responsible for producing your bile, your clotting factors, as well as your albumin and cytokines. As for the metabolic, of course, it would aid us in the digestion of the macronutrients, as well as detoxification of your drugs. That's why when we do tests, or LFTs, na narinig niyo in the wards, or LFTs, or liver function tests, yung panel is composed of laboratory parameters that will be used to test both synthetic and metabolic functions, as shown as the table here, diba? For example, your ALT and AST are markers of hepatocellular injury. Okay, amongst the two, mas sensitive yung liver or yung ALT, kaya ko siya in-underline here, because mas sensitive for hepatocellular injuries, ALT more than your AST. And to test for the synthetic functions, as said, liver is responsible for producing albumin. Therefore, kung mababa yung serum albumin ng patient mo, meaning partly the liver is not functioning well or not synthesizing well. And also the clotting factors, okay, are also produced in your liver. That's why you can also test for the PTT of your patient. It's also indicative of the synthetic function of your liver. And as well as for the metabolic part naman, or at least for the drainage part of the bile, that would eventually that will eventually digest your fats, you can test for the bilirubins, the alphos or alkaline phosphatase, and then your GGT. Okay? So, enough with the introduction. Let's go to the pathologies. In this slide, I'd like to show you the spectrum of pathologies that can be associated or found in the liver. Okay, it could span from your liver cirrhosis up to the malignant liver tumors. But for the top-notch genesis program, we have identified the last 3, your hepatic abscess, benign and malignant liver tumors, as conditions that are parang surgical in nature, or the management would most often than not would require a surgical referral. Kumbaga, the other topics it would be discussed more thoroughly in the internal medicine, pediatric part of the programs. So at least kumbaga, these are the particularly in surgery that you have a good grasp on. That's why we will be focusing our discussion on those 3 topics. So what is the diagram on the right? What does it tell you? It would be a recurring image in my slide, because I believe you guys are lucky because this is the strength of the top-notch genesis program. Because when I was a med student, or I think many of you would have experienced this already, when you read your textbook, you tend to get overwhelmed, and your tendency is to aim to memorize every single detail. Kumbaga, from the more common one to the rarest forms, diba? Yung gusto mo parang, I must know them all. But in reality, that's not how medicine works. In medicine, it's a stepwise manner, and with the top-notch genesis, we'd like you to be accustomed first, or at least very well versed with the common conditions first, and as you go up or as you gain more experience, okay, dyan na kumbaga dagdag lang ng dagdag, build up on your foundation. So that's what we're gonna do now. We're gonna start building your foundation. So far, when you go to your clinical rotations, or may counter nyo siya ng rare, kumbaga add on lang siya. So beginning first with your hepatic abscess. So simply put, abscess is a collection of pus. It could be bacterial, fungal, or parasitic in origin. So how would your liver gain or magkakaroon ng abscess? It could be of three mechanisms. First would be a direct extension from an intra-abdominal infection. Diba? It's one big cavity. So the infection can come from spillage from your GI tract. Diba? It could come from the venous circulation, from an infection elsewhere. Okay, in the same manner, pwede rin siyang hematogenous, or ibig sabihin, kung may sepsis or mayroong bacteria in the blood of the patient, that bacteria can get lodged into the liver. Kaya mag-abscess din siya eventually. And of course, pwede rin traumatic. For example, a stab wound in the liver. Okay, eventually, it could cause development of an abscess. It is more common on the right lobe simply because the right lobe is bigger than your left lobe. So, kumbaga more areas where the abscess can develop. Alright? So hepatic abscess has two main types, your pyogenic or your bacterial versus the amoebic, or yung amoebic natin, ito yung mas parasitic. But amongst the two, okay, in terms of presenting as abscess, sabi nila mas common yung amoebic worldwide. Okay? But usually in the Philippines naman, in the Philippine setting, mas common natin nakikita yung pyogenic or bacterial. So yung pyogenic or bacterial, most common, if you take out the abscess, make a culture and sensitivity test, most of it would yield polymicrobial results. Or sabihin, not more than one microorganism can be isolated from the abscess. And do sa polymicrobial na yun, at least 2/3 or majority would have positive growth of E. coli or a gram-negative organism. So others, may makitang pleb, hindi naman common. Pero ang pinaka-importanting malaman nyo dito is the presence of a gram-negative organism, particularly E. coli, because that actually will guide you on your choice of your antibiotic. Okay, in terms of amoebic, we have encountered it in parasitology. It involves the presence of Entamoeba histolytica. And infective stage now is if you would ingest a cyst, and then the pathogenic state would be the trophozoite form. So, ang magiging nadalas na narinig dito would be the appearance of the anchovy paste. Diba? Ay, parang buzzword for that. If you aspirate, and then yung nakuha mong fluid, parang anchovy paste, or parang bagoong siguro, para mas relatable in Filipino terms, that is almost always indicative of an amoebic form of hepatic abscess. So this Entamoeba histolytica, if you would remember your para, the infected stage would be the cyst, and then the kumbaga yung pathogenic state would be your trophozoite, and ito yung anchovy paste, parang brownish, di ba? Parang bagoong nga. So clinically, how would you differentiate a pyogenic from amoebic liver abscess? So dito, if you would look at it, parang almost the same naman yung presentation nila. Since it's an infection, the systemic manifestation of a infection will always be there, di ba? Almost sa kanila may fever, may associated din na pain. Okay, jaundice is variable, hepatomegaly is also variable, and look at their laboratory markers, di ba? In the laboratory markers, your WBC or ESR, or kumbaga yung mga indicators mo for inflammation and infection are always there. Because di ba nga, part and parcel, the etiology is related to an infection. And then with amoebic liver abscess, bukod sa direct microscopy, you can also do fluorescent antibody test, diba, to detect the presence of your antibodies against Entamoeba histolytica. In hepatic abscess, commonly nakita yan via an ultrasound. Diba? Yun naman yung usual imaging of choice natin when it comes to the liver. Or actually, in the Philippines, common na ginagawa ultrasound because it's mas mura and mas mabilis siyang gawin. But if you do a CT scan, okay, it could help you identify also this is how a cyst looks like. So cyst, diba, pag narinig niya yan, balloon, para siyang lobo or balloon. So meron kang rubber na wall, and then what's inside is actually fluid filled, diba? Pus kung pyogenic, kasi yung anchovy paste, itch na itsura if it is amoebic in nature. So paano mo siya ma-differentiate? When you do CT scan with an IV contrast, yung hepatic, pag abscess siya, you would usually see the enhancement on the rim. Or ibig sabihin, iilaw yung paligid. Or the cyst capsule, iilaw siya. Okay, like this one. So this is example of your imaging finding of your hepatic abscess. And usually, CT scan, if done well, done right, with the right contrast, can be diagnostic if it's indeed an abscess or not. Okay? Hepatic abscess, madali lang naman gamutin yan. It's an abscess. Imagine nyo lang may pigsa ka, pero yung pigsa mo nasa liver. So how do you manage a pigsa or a boil? Of course, you have to start broad spectrum IV antibiotics. So with your knowledge, for example, na it is a gram-negative bacteria. So, ang gram-negative, diba, as you know, as you go through your pharma knowledge, cephalosporin could be a good choice. Pero cephalosporin, diba, as you go higher the generation, mas maganda yung gram-negative coverage nila. So, yung mga options mo dyan can include ceftriaxone, okay, for lower, pwede ka rin mag-cefoxitin. Those are the choices you could have for your antibiotics. And of course, dahil may abscess, what do you usually do kapag mayroong abscess or may pigsa? You have to drain it. So, for this one, you can do a percutaneous drainage, or ibig sabihin using imaging, okay, i-guide nyo yung puncture site so that the tip would be lodged inside the abscess and you would aspirate it lang. Okay, and then the aspirate you would send for culture and sensitivity. And if tama yung coverage ng antibiotic ninyo, okay, the chances of it recurring can be low. Okay, again, granted that you have started the correct antibiotic for it. And of course, for an anaerobe coverage, for example, you're also suspecting na baka may anaerobe component ng infection ninyo, it would also be prudent to start your metronidazole. Okay, and also kung sakali pag-aspirate nyo mukhang amoebic yung hepatic abscess, the same management din naman yung gagawin nyo. You would also start metronidazole, okay, with a dose of 750 milligrams 3 times a day for 7 to 10 days. And then the etiology being an infection, pag na-resolve na yung infection, it is no longer expected that it would recur, diba? Kumbaga mag-regress na yung abscess ninyo pag na-complete na or na-eradicate na yung source of infection. Okay? So also, when you're managing with your hepatic abscess, 50% of them would yield a positive blood culture. Okay? If you would remember, di ba, one of the routes kung paano ka magkakaroon ng hepatic abscess would be through hematogenous spread. So usually at the time of the workup, half or 50% of them would have the same growth on the blood, okay, and the same growth din yung lalabas doon sa hepatic abscess. It's worth noting this also because kung matagalan or madelay yung pag-aspirate or yung capacity nyo to drain the hepatic liver, or the hepatic abscess rather, the growth on the blood or the blood culture can also guide you in your choice of antibiotics. So going back to this diagram, we're done with hepatic abscess. We're going forward with the benign liver, actually liver tumors, both benign and malignant. So, this is a common presentation when you do your outpatient clinic or meron ka ng mga kamag-anak in family gatherings that would show you an ultrasound or a CT scan finding na meron akong something sa liver. So dito, usually pag meron kang lesion sa liver, it would help you if you can differentiate if it is cystic or if it is solid. Because kung cystic yan, iba nang usapan dyan, di ba? Katulad ng makalispasan natin kanina, it could be an hepatic abscess or it could be a benign cyst, di ba? Kung sabi natin, cysts are most frequently encountered liver lesions overall. So meron tayong mga congenital types na usually benign naman of course with no intervention needed, and meron mga secondary, for example, post-traumatic, post-infectious, or very rarely associated with neoplasm. na mga cysts. Alright? So kung cysts sila, usually benign, and usually no intervention is being required. But if solid mass na ang nakita on ultrasound or CT scan, ibang usapan na yan. So grossly, this is how your workup should be. Of course, sabi natin, kailangan history and physical exam. Diba? Bates would be proud if you remember na sabi ni Bates, 80% of the diagnosis can be clinched with a good history and physical examination. So these are some of the things that are kumbaga pertinent when doing hepatic-related history. So yan, weight loss, constitutional cirrhosis, hepatitis, use of OCP, jaundice, palpable mass on the right upper quadrant, and then stigmata of portal hypertension or liver cirrhosis. So mga example natin dyan, varices, diba? Hematemesis, ascites, testicular atrophy, yan yung mga stigmata of portal or liver cirrhosis. Also, you could request for adjunct laboratory test. Ang pinaka-important dito, di ba, yung napag-usapan natin during the introduction, as like your LFTs, and then your liver function test, and of course your hepatitis markers. And then later, when you go through specific conditions, if you have high suspicion for malignancy, you could request for tumor markers to help you clinch the diagnosis. And from there on, pwede ka mag-proceed in requesting further imaging. Pero look at this, di ba, especially also in the Philippine setting, ultrasound talaga kadalasan yung nauna. Yung liver biopsy, ito na yung medyo dangerous dito. Liver biopsy, hindi ka diretso lagi for all cold conditions, di ba? Sa mga ibang mass or sa ibang oncotopics ninyo, kadalasan sa kanila would require a tissue diagnosis before proceeding with management. In the liver, it's not. Okay? Hindi lahat binabiopsy kapag liver, even before initiating treatment or surgery. So, let's start first with the benign solid lesions. So, for benign liver conditions, we'll be discussing 3 topics lang. Your cavernous hemangioma, your hepatocellular adenoma, and then your focal nodular hyperplasia. Cavernous hemangioma is usually the most common solid tumor of the liver, and it occurs for all ages. Again, common na naman siya on the right side kasi mas malaki yung real estate natin, or mas malaki naman talaga yung right liver lobe, kaya mas madala siya. It is associated with pregnancy and estrogen therapy, and usually incidental finding lang ito. And usually with a good CT, okay, kaya nang i-diagnose by CT na if it is just a simple cavernous hemangioma, usually enough name CT to call it as such. For this condition, again, do not biopsy because if symptomatic, if it causes pain, that's the only time you would intervene via a surgical resection. Sabi ko kanina, a good CT is enough na for you to diagnose or to tell the etiology or the reason for the hepatic mass. In the case of cavernous hemangioma, you would be needing a dual phase CT or short dual phase. So, sabihin, it would entail na meron ka dapat IV contrast. Okay? So, here on the CT scan, on dual phase CT for cavernous hemangioma, it would show you a symmetrical peripheral enhancement, hindi pantay-pantay, na enhancement of your capsule, and then progressive centripetal enhancement. Although not entirely seen in this picture, it's worth noting lang paulit-ulit ako. In this, usually a good CT scan or yung properly done CT scan is enough to clinch a diagnosis for liver. Okay? Kaya when you do your practice, if you go out to be a GP or general practitioner, usually kapag liver condition, ang best bet nyo is to do a CT scan with an IV contrast. Okay? Kumbaga, if you're gonna bet on it lang. But of course, hindi naman din lahat ng CT scan with IV contrast pare-pareho yan. So it's better that you refer them to a system or to a hospital na may mga specialty studies just for the liver. And usually, we call them triple phase or triphasic contrast CT of the liver. Okay? Iba ang triple phase sa triple contrast. When you say triple phase, okay? Phases kung kailan siya kukuhanan ng CT scan. Usually, it would entail ay plain phase muna, ibig sabihin, before mag-inject ng IV contrast, that's your plain. And then arterial, ibig sabihin, the CT scan would be captured in the time na yung majority of your contrast ay nasa arteries, or yung highest concentration niya would be in the arteries. And then for the liver, meron tayong tinatawag na portovenous phase, or ibig sabihin, the contrast are already in the portovenous circulation. So kapag nandun na yung contrast, saka i-take yung CT scan. So those are the triphasic or triple phase CT scan. In contrast to a triple contrast CT scan, usually naman yung triple contrast, you encounter it sa mga GI conditions like your colorectal CA or bowel obstruction. When you say triple contrast kasi, usually yan, may oral contrast, ibig sabihin, papainumin siya ng radio-opaque na fluid. And then meron rectal contrast or lalagyan siya ng contrast sa puwet. Okay? And then the third contrast, magiging IV naman siya. So, kumbaga, kaya siya triple contrast, 3 types of contrast yung ginamit. Oral, IV, and then rectal. Okay? Makakatulong yan kasi especially if you'd like to visualize intraluminally or ibig sabihin what's inside the GI tract or your bituka or your intestines. Okay? Medyo nasa tract tayo doon. But gusto ko lang i-note yun because common siyang nami-misorder or hindi naiintindihan or nami-miscommunicate sa words. Iba ang triphasic at iba ang triple contrast CT. For liver conditions, usually a triphasic CT ang magiging useful or commonly used in the clinical sense. Okay? So, going with the second condition of your benign liver tumors, we have the hepatocellular adenoma. Again, this is benign. And then ito, kumbaga, ito yung if you have a female presenting with a benign liver tumor and then with strong history of OCP use, ito yung best bet mo or yung pinakamalamang na diagnosis niya. It is the one that is associated with a rigorous fear factor for OCP use or hepatocellular adenoma. Yung complications ito can include a rupture or hemorrhage or dumugo. And then it could go malignant degeneration. And of course, the treatment for this one is to discontinue the OCP. Some of them would regress spontaneously. And if may chance siya or masyado ng malaki, na dumudugo na, okay, of a liver resection or magpe-pain yung patient mo, okay, right upper quadrant pain, na wala ng ibang attributable cause, a resection is a viable option also. The third benign liver tumor is the focal nodular hyperplasia. Ito naman occurs commonly in the young women rather. Tapos katulad din siya naman ng conditions. You would not intervene unless it causes pain or it is bleeding. Ito naman on the CT and MRI, it would tell you of the central scar. Okay? It is common na meron kang central scar dyan because if you go back to the pathophysia of focal nodular hyperplasia, it is usually results for hyperplastic proliferation around the dystrophic artery or injury. Or ibig sabihin sa site na to na hindi maganda yung blood supply. Pwede ng ischemia or pwede nagkaroon ng trauma. Therefore, di ba kapag nagkaroon ka ng trauma or sugat, magkakaroon ng wound healing dyan. Magkakaroon ng fibrosis. Kaya on the CT scan, ang itsura niya parang meron kang scar. Okay? So ang treatment for this, parang yung mga naunang conditions natin is just observe and intervene only if it causes pain or hemorrhage. So ito, usually yan yun. Sa young patient, okay, na meron ka on CT scan na appearance of a central scar, and if you do a nuclear scan, it labels as a hot lesion, or sabihin may ilaw siya if you do a nuclear scan, it is most likely pointing to focal nodular hyperplasia. So, going back to our outline, we're done with hepatic abscess, we're done with the benign liver tumors, and then now we're going to start discussing about your malignant liver tumors. For malignant liver tumors, meron tayong tinatawag na primary and metastatic. Tapos yung pangatlong type, if you would notice, nakadim or not so bright in color. Because, okay, may natin siya discuss in terms of the liver and discuss din natin siya sa biliary system. Okay? Sa malignant liver tumors, kung may makita, Dok, may bukol ako sa liver. The first differential you would be thinking of is it primary or is it metastatic? Ibig sabihin, sa liver ba talaga yung bukol or nakalatan lang ba yung liver? Amongst the two, mas common yung second scenario, which is yung liver mass is actually a metastasis lang from another primary or nalipatan lang siya noong primary natin. It is the most common malignant liver tumor, and kumbaga amongst all the cancers, ang common natin nakita would be from the colon or metastasis of colonic carcinoma to the liver. Ngayon, kapag yung tumor ay sa liver mismo nanggaling, primary ang tawag natin doon, and ang most common doon would be the hepatocellular carcinoma. Okay? So hepatocellular carcinoma, sabihin natin, it's a primary malignancy arising from the hepatocytes themselves. Or sabihin, intrinsic sariling cells ng liver yung nagkaroon ng cancer or nagproliferate. So the risk factors for hepatocellular carcinoma would be cirrhosis, hepatitis C infection, steatohepatitis, chronic B hepatitis, exposure to aflatoxins in migraine, discuss na yan, di ba, yung mga fungus, and it's more common on males. Sabi nila, preventable daw ang hepatocellular carcinoma. Yes, it is through vaccination. Indirectly, if you get vaccinated with hepatitis B, you would be prevented from having chronic hepatitis B, which is a common risk factor for the development of your hepatocellular carcinoma. So that's why they say na HCCA is preventable. Okay? So typically, it is hypervascular and it's derived from the hepatic artery. The diagnosis would be usually CT MRI, and then tumor markers associated would be your AFP or alpha-fetoprotein. So why the CT scan here is in bold, I think I have stressed this enough in the previous slide. Hepatocarcinoma or hepatocellular carcinoma are usually asymptomatic with early disease. Okay? Ito yung good and bad about it. Hindi siya nagkakos ng symptoms, but it delays the diagnosis. Or usually when we get patients with HCCA, medyo advanced na yung sakit nila or ang laki na ng bukol. But if they become symptomatic and their history, you would usually elicit abdominal pain, weight loss, or satiety and palpable mass in the area of the liver. And mas common pa actually, more than the symptoms of this listed, mas common nung pa sila nakikita na meron silang mga signs and symptoms associated with liver cirrhosis. So ito na yung mga nag-ascites sila, diba? May nakita ka na pwede sila hematinesis, nagkakaroon ng signs of liver decompensation rather than the tumor actually developing. Okay, late na yun usually. And with the diagnosis of hepatocellular carcinoma, ito na naman tayo, I cannot stress this enough. Okay. May personal hugot ako about this because in the clinics, when I used to do outpatient clinics for GS3, ito yung common ko nakikita. In the general practice, order ng triage doctor ng CT scan with IV contrast. So tama naman yung intention niya. But in terms of the liver, it could be more of help or kumbaga yung mas tama or more appropriate request should be a CT or a triphasic CT of the abdomen because it would help you clinch the diagnosis and it would help you also assess eventually for resectability of the tumor. Diba? Kasi medyo mahal din ng CT scan. It's not helpful for our patients if paulit-ulit yung test. That's why if you get the chance, do what is right, do what's what appropriate para isahan na lang. Okay? So triphasic CT of the abdomen or the upper abdomen. And at the same time, you could also request, if you have high index suspicion that it is HCCA based on the history and physical exam, you could already request for AFP or a tumor marker for alpha-fetoprotein. Usually the cutoff for this one is 20 nanograms per milliliter, and higher than that, or if elevated siya, it has 60% sensitivity. That is, it is indeed hepatocellular carcinoma. Okay? Biopsy is not often required. Yes, hindi mo kailangan tusukin yung bukol. Usually, kapag yung CT scan mo already points to a hepatocellular carcinoma, dagdagan mo pa ng elevated AFP, almost always enough na yun to clinch the diagnosis. Okay? Or to do surgical intervention. The dangers with this one kasi, first, there is theoretical meron ko ba may theory na when you puncture the liver, okay, yung tract, pwede siya mag-seed. Or sabihin, pag tinusok mo yung bukol, pag na-draw mo daw ng needle, kung saan dumaan yung needle, you could leave seeds of the tumor, and then the tumor can actually grow down from the tract. And I have seen some cases of this already, okay? Kaya sometimes, when the CT and the AFP are incongruent, usually you go straight ahead with planning for resection or kung resectable ba yung tumor, okay? This is the point that we'll have to give credit to our radiologists. Kasi they can already call, or meron tayong matatawag, di ba, pathognomonic na tinatawag, or ibig sabihin kapag ganoon yung imaging finding na nakita nila, almost always suggestive na siya of the correct diagnosis. As for the case of your hepatocellular carcinoma. So, eto, whole abs nga tayo ulit, di ba? With triple phase contrast. So, yung radiologists mo dito, they would be able to see arterial enhancement with rapid washout during the portovenous phase. Okay? This is the plain study. Ito, arterial phase, lumabas na yung bukol. And this is the portal phase, or yung magkakaroon tayo ng washout. Kung ganito yung na-observe nila na appearance or characteristic of the mass during the imaging, this is almost always pathognomonic or indicative na of HCCA. I-couple mo pa siya with AFP, enough na siya to clinch the diagnosis. Instead of doing a biopsy, paplanuhin mo na, anong segment kaya ito? Kaya siyang tanggalin na kung yun lang yung bukol? Okay? Yun yung iniisip ng mga surgeons ninyo when faced or confronted with a hepatic mass likely to be hepatocellular carcinoma. Okay. In managing hepatocellular carcinoma, kaya mo siya i-categorize into 3. Okay? Of course, ang gusto mo sana would be resection. Okay? Kung kaya mong tanggalin yung bukol, take it out. Okay? That's where your knowledge of your hepatic segments would come in handy. Okay? Kung nasa segment 7 lang, just take out segment 7 and you're good. Okay? But also, kailangan mo ring maalala dito, yung tinatawag natin na liver volume. Okay? Because you have to have enough liver remnant para hindi naman nag-liver failure yung patient mo. The good thing about the liver is it could regenerate. Okay? But regeneration would take time, and regeneration, dapat meron kang premise na maganda pa yung liver mo. And if you would remember, the common risk factor for hepatocellular carcinoma is liver cirrhosis. So most of the time, when you get patients like this one, hindi na ganun kaganda yung baseline liver function. Pwedeng by volume or by size, mukhang malaki pa yung maiiwan. But kung yung maiiwan naman na malaki is non-functional or poorly functional, di ba? Parang paano yun? Hindi rin enough in totality yung maiiwan na liver volume for your patient. But again, sabi nga natin, kung kaya namang i-resect or tanggalin yung bukol, if the liver is non-cirrhotic, child view A, single lesion lang and no metastasis, resection is your best bet. Okay? But others would go to a more conservative route, o yung mga ablative therapies, or ito yung kumbaga mga sinusunog or in-embolize yung bukol. So meron yan yung mga RFA, okay, parang meron yung microwave, meron yung chemoembolization. So the idea there is ablate or susunugin mo lang yung maliit na bukol and hopefully that's enough to control the tumor. Usually ito for mga patients that are not good surgical candidates, or ibig sabihin baka may cardiac problem, may renal problem, that could cause them risk for a resection. Okay? Kasi resection is a major surgery. So hindi lang naman you have to look at your patient in totality. Hindi naman basta may liver mass, resect na agad yan. Paano kung may liver mass naman pala, tapos mahina yung puso? Okay? Hindi yung bukol ang papatay sa kanya, but rather the risk of the surgery itself. Okay? And what if naman napakalaking bukol or hindi na siya resectable? So an option could be transplantation. So what happens there? Kung for example, ang laki-laki ng bukol, it spans the whole right lobe, the remnant lobe will not be enough. So the idea goes, just take out the liver, okay, and then transplant a liver from a donor. So kumbaga tinanggal mo na yung buong deceased liver, papalit ka mo na ng bago, di ba? Parang ang nice, para tayong partly, masamang sabihin, parang kang kotse, di ba? Tinanggal yung deceased part, tapos binigyan ka ng spare parts, and then your spare parts can come from a donor. But yun nga, this part is easier said than done, okay? Because transplantation itself has its own risks and complications. And then, of course, the financial aspect of it, especially in the setting of our country, hindi to ganun kabilis nagagawa. But it's worth noting that it's a viable option for liver carcinomas. Okay? Kaya pa tayo discuss about liver cirrhosis. I'm sure you're familiar with this one, with what we call the Child-Pugh scoring. Kung nakapag-rotate na kayo in surgery, lagi itong ginagamit because it's a grading scale for liver cirrhosis, and the components niyan, if you look at it, bilirubin, albumin, INR, ascites, and encephalopathy. Parang, di ba, if you go back to our previous discussion, this is related to the two functions of your liver, your systemic, or your synthetic, yung capacity niya to synthesize, as well as to detoxify, okay, your body. So the components niyan, ang mnemonic natin dyan, BAIAE, di ba, or lagi ito na-encounter sa asthma, bronchial asthma in acute exacerbation, bilirubin, albumin, INR, ascites, encephalopathy. Basically, ang bird's eye view niya dito, okay, mas maganda yung Child-Pugh, mas mababa, or class A ang Child-Pugh niya, 10% mortality lang siya because of the cirrhosis. Ibig sabihin, mas good yung surgical risk nila for a resection. Whereas, kung tumataas yung classification nila, or tumataas yung points nila in the Child-Pugh scoring, yung associated mortality nila, not from the mass, but from the cirrhosis pa lang, has high mortality agad. Kumbaga, hindi ka pa nga nag-opera, cirrhotic na yung patient mo, talo ka na. Because yung, on that condition alone would entail high mortality rate. Sabayan mo pa ng surgery, sabayan mo pa ng mataas na blood loss, di ba? So that can compound to the surgical risks of resection. That's why when you receive a patient with hepatic mass, usually pina-Child-Pugh scoring mo na rin sila para makita mo na if they are good surgical candidates for a resection. Going back to the slide, okay, metastatic tumor, madali lang yan, tapos tayo with the primary tumor. Okay? So, but gusto ko lang i-reiterate at this slide na yung metastasis to the liver, usually asymptomatic yan. Okay? But kung meron kang makitang symptoms sa kanila, usually systemic or kumbaga constitutional lang din na tinatawag. Now, these are the signs and symptoms non-specific for anything but commonly associated with malignancy or cancer in general. Diba? So, the grossly ganyan itsura, parang cannonball, parang satellites. Usually, pag ganyan yung presentation, it's more commonly metastasis to the liver rather than it being a primary. And then, pag binayopsy mo yan, ang lalabas dyan ay hindi hepatocytes na cancer, but rather kung ano yung primary, kung colonic adenosine yung makita mo dyan. Okay? So, third part natin, yung naka-dim, is the cholangiocarcinoma. Okay? For the sake of our discussion for today, medyo nakakalito po in where we would put this, if it's under the biliary system or under liver. But clinically kasi, pareho naman yung presentation nila. Makikita mo yan on imaging as an intrahepatic mass or liver or mass within your liver. That's why it's worth discussing also in the context of liver tumors para kasama siya lagi sa differentials ninyo. The difference is, with cholangiocarcinoma, the malignancy came from the bile ducts. Hindi parang HCCA that the malignancy came from the hepatocytes. So yung biliary system natin, if you could remember the diagram before, meron tayong intrahepatic and extrahepatic, diba? Self-explanatory naman. Yung duct system that are still inside your liver is intrahepatic. Kaya represent siya as a hepatic mass. But if it's outside, it will be proximal or distal. But again, the malignancy come from the bile duct. And its presentation is right, kapareho din siya ng HCCA, right upper quadrant mass, weight loss, but I'd like to highlight lang that jaundice is more prominent with cholangiocarcinoma. It's biliary system nga yan. Pag nagbara yung biliary system mo, okay, bile would accumulate, therefore leading to jaundice. Okay, sabi natin not specific for cholangiocarcinoma, pero kung mag-present with jaundice, higher chances na cholangiocarcinoma siya rather than being hepatic primary or hepatocellular carcinoma. Cholangiocarcinoma can be considered rare, but it's often lethal. And for our discussion, tandaan nyo lang ito, may daanan pa rin naman natin ito, what we call the Klatskin's tumor. Ibig sabihin nito, if the mass is in the hepatic duct or in the confluence or bifurcation. So, reviewin lang natin, di ba? This is your gallbladder, this is your cystic duct, and this is your hepatic duct. Okay, your hepatic duct is a confluence of your right and left intrahepatic ducts. Pag nandito yung bukol mo sa confluence ng right and left, okay, yan tinatawag natin na Klatskin tumor. Okay, mamaya babalikan pa natin yan. The diagnosis for cholangiocarcinoma, okay, para din siyang liver tumor. You can do a CT scan or multiphysics CT scan with or without MRCP. The MRCP, sabi nila, it's good to visualize the hepatico-pancreatic duodenography or makita mo yung buong liver, biliary system, as well as yung drainage ng pancreas mo. Dito, at this point, tumor markers, wala talaga siyang solo for cholangiocarcinoma. But sabi nila, if pagsamahin niyo yung elevation in CA19-9 and CEA, if it both are elevated, can support the diagnosis of cholangiocarcinoma. This part, medyo controversial pa rin to, and it is evolving pa din. Okay? I included in the discussion because if you do your OPD or outpatient clinic, pag may hepatic mass yung patient and na-work up na siya by a GP or a general surgeon, they always come into you with this work up na may AFP na, may CA19-9, and meron kayong CEA na din. So, ano yung thought process ng doctors na nakita sa kanila previously? Ito yun. Okay? At an elevation in CA19-9 and CEA, although not specific to cholangiocarcinoma, pag pinagsama mo sila, can support a diagnosis of cholangiocarcinoma. And that's just like our other liver tumors, biopsy is not often required to clinch the diagnosis. Usually, CT scan or imaging pa lang, kaya mo nang clinch yung diagnosis. And for this one, sabi natin, surgical resection is the gold standard pa din. So if you could take out the whole tumor, that's the best chance of cure for the patient. But anong sabi natin? This is rare, this is lethal, and usually the presentation is late na in the disease process. So the more common patients that we have encountered with cholangiocarcinoma, usually parang palliation or palliative yung nangyayari. So what you do usually is you address the obstruction via stenting, lagyan mo ng parang plastic or straw that would aid the drainage of your bile or pwedeng surgical bypass. And then kung hindi talaga kaya, percutaneous drainage or through the skin, ilalodge mo siya within the intrahepatic ducts para yung bile mo, instead of draining doon sa biliary system, would be drained out through a bag na lang or magkakaroon ng bag yung patient, doon na pupunta yung bile. So we are done with the pathologies of liver. We were able to tackle these 3 conditions. So that's the end of our liver segment. Moving forward, we'll be now discussing the gallbladder. I am sure at this point, kahit med students or clerks or interns na kayo, may lumapit na sa inyo sa Facebook na nagpabasa ng ultrasound nila. May tito and may tita na nagsabi ng may gallstone sila, patingin ng ultrasound nyo, di ba? And that's why it's worth discussing with top-notch genesis. So parang the liver, review of relevant anatomy lang, this is your gallbladder, okay? Right and left hepatic ducts, common hepatic duct, cystic duct, it would form your common bile duct. And then your gallbladder is being supplied by your cystic artery, okay? It's usually 7 to 10 centimeters long, ang capacity niyan would be 30 to 50 ml, and it is intimately related with the inferior aspect of your bladder, of your liver rather, and then meron siyang 3 parts, diba? Your fundus, your corpus, infundibulum, and then meron tayo neck, okay? In terms of pathologies of the gallbladder, ito yung ulit yung mga na-identify nating conditions that you should master at this point or at this level. So, tatlo lang yan. Let's start with the first one, or gallbladder polyps. Most gallbladder polyps are of cholesterol type and have no malignancy potential. So, polyp siya, so parang pedunculated, ganyan. Meron siyang stalk, tapos meron parang pendulating na mass dun sa dulo. Almost all malignant polyps are more than 1 cm in size. So, ang gusto lang natin dito, at this point, polyps sa gallbladder, kailangan ba operahan? Hindi. Kadalasan, hindi sila kailangan galawin. But if you see the presence of yung mga yan, it could be associated with a malignancy. So, ibig sabihin ba yan, opera agad? Hindi naman. Okay, sabihin lang, baka kailangan lang bantayan yung patient. And if indeed meron talaga siyang risk of developing malignancy, maybe you could prescribe, or symptomatic din naman yung patient, maybe you could suggest to them that they undergo cholecystectomy. Okay, but polyps in general, pwedeng consider na benign. So, gallstone diseases, the risk factors for this one includes female, obesity, pregnancy, Crohn's disease, related with malabsorption, gastric and terminal ileal surgery, hemolytic disorder, and biliary stasis. Ang natural history niyan, most would remain asymptomatic. Repeat, most would remain asymptomatic. Isa pa, most would remain asymptomatic. Okay, yun dapat yung mantra ninyo to everyone telling you na meron akong gallstones. Okay, most of them are incidental findings lang. Kung baga, kung hindi sila nagpag-ultrasound, hindi nila malalaman or nakagip lang sa ultrasound, kaya nila nalaman na meron silang gallstone disease. But if not symptomatic, most of them would remain asymptomatic. And usually for any gallstone disease, ito yung nangyayari dyan, or stasis, diba? Sabi natin, common would be your cholesterol stones here. So, what happens there is nag-saturate siya. Kumbaga, nagpo-produce siya ng salts, and then eventually mag-supersaturate, and then mag-aggregate siya to form your cholesterol stones. And since it is stored in the gallbladder, doon siya magla-lodge, okay, and doon siya lalaki ng lalaki, or pwedeng dumami. In terms of gallstone disease, diba? Ito ulit yung spectrum ng conditions associated with your gallstones. Or, pag sinabi mo kasing gallstones, ano ba yung general term for gallstones? It's cholelithiasis. Gole, parang pertaining to the gallbladder. Lithiasis, ibig sabihin related with a stone. So, cholelithiasis, when you say it's cholelithiasis, it's a disease of the gallbladder related to a stone. Okay? In general term, kung nasaan man yung stone na yan, di natin sure. Basta meron siyang stone causing a clinical condition of the gallbladder. But when you say it's cholestolithiasis, cysto, yung additional term na nadagdag, cyst, okay, parang may balloon. So, ibig sabihin, nasa loob ng gallbladder mo. So, usually stones in the gallbladder would entail, or yung medical term would be cholestolithiasis. Okay? And most of them would be asymptomatic, and others may cause biliary colic. So, doon tayo mag-start muna. As previously mentioned, most of patients with cholestolithiasis are symptomatic, but those that would present with signs and symptoms would actually present with what we call collectively as biliary colic. It's a type of pain, so let's further characterize it in terms of PTRSD. So usually in terms of timing, the pain is postprandial, or ibig sabihin after having a fatty meal or having meals. If you would remember from physiology, after eating, cholecystokinin, a hormone would be released, and one of its action is to trigger contraction of your gallbladder. This contraction would lead to the eventual drainage of your gallbladder. The bile would be expelled out into the duodenum, thereby the bile would help in digesting the fat. Okay? But the problem with cholestolithiasis is there is transient obstruction of the stone, meaning the stone that is originally in the gallbladder lumen would lodge transiently in the cystic neck, okay, upon contraction. But when the contraction ceases, the stone can move back, or the obstruction can be relieved spontaneously, thereby the pain resolves spontaneously after 1 to 5 hours. Okay? And the pain is usually epigastric end location, really eating to the back and shoulders. And I could not stress this enough, the pain is again episodic. It only happens when the cystic stone transiently obstructs the cystic neck or the cystic duct. And after the contraction, it moves back. Therefore, the flow returns to normal again, thereby hindi na nagpipain yung patient natin. Okay? That is the classic type of biliary colic. Of course, because it would involve some form of difficulty in digesting fat, associated symptoms with biliary colic would include signs and symptoms associated with maldigestion. For example, vomiting or dyspepsia and flatulence. Okay? Symptoms ka, naging symptomatic ka na, baka kailangan mo ng elective cholecystectomy. Okay? Because we can never tell kung mauulit ba siya ulit or kung kailan ba siya mauulit. So habang hindi pa siya emergency, it's better that you consult with a surgeon para magkaroon ka ng management, which is cholecystectomy. Ngayon, if meron kang gallstone disease, you are asymptomatic, most of them again would not require treatment, except for yung mga napag-usapan natin kanina. Except for if may chances siya or if risk for bladder cancer. Yun lang yung kinakatakot natin dyan. Although this one is very rare, those documented lang na risk or merong risk or association. Di ba magkaiba pa yun if you remember your PrevMed? Diba ang risk, iba ang association. Na kumbaga, anomalous pancreatic duct drainage, presence of gallbladder polyps more than 1 cm, tulad sabi kanina, large stone burden or large stones greater than 3 cm, and then porcelain gallbladder, kapag yung mga findings sa inyo on imaging. It could be at increased risk for bladder cancer. Risk lang. Ibig sabihin, hindi talaga siya yung main na cause kung bakit ka nag-develop ng cancer. But in studies or stats would tell us na kapag meron yung mga taong may mga ganitong conditions, sila din yung nagkakaroon ng gallbladder cancer. But siya ba yung nagkakause ng bladder cancer? At this point, hindi natin alam. But, kumbaga, sa survey, yung mga tao na to, ito yung mga characteristics ng mga nagkaroon ng gallbladder cancer that are associated with gallbladder cancer. And then for some hemolytic disorders like your sickle cell and hereditary spherocytosis, it can be considered. Okay, yung term na ginamit natin can be considered. Okay, because these conditions predisposes them to having gallstone or magkakaroon talaga sila ng gallstone. Therefore, unahan mo na. Okay, na mag-tanggalin yung gallbladder nila because likely they would develop gallstones in the future, and then yung gallstones sila would likely to be symptomatic. Therefore, you can consider intervening if you have sickle cell or hereditary spherocytosis. Here, okay, this is a picture I lifted directly from Surgical Platinum because I think your other teachers or you would encounter this also, na dati kasi mayroong mga indications na tinatawag for prophylactic cholecystectomy. When you say prophylactic, ibig sabihin kahit asymptomatic yung patient, operahan mo, tatanggalin yung gallbladder. Although with research and development, hindi na siya masyadong pinapractice ngayon, but it's worth knowing pa din. And there was a time na ginagawa natin yung mga prophylactic cholecystectomy. For example, diabetic patients, cirrhotic patients, transplant recipients, yung mga may porcelain gallbladder. Yung porcelain gallbladder, it's nakikita yan by ultrasound na mayroong curvilinear stick or parang mayroong bato doon sa mismong gallbladder wall nila na they call porcelain gallbladder. Those patients on TPN or parenteral nutrition and those with spinal cord injury, and morbidly obese after bariatric surgery. Yung textbooks na yan, abutan ko pa while in med school. Meron pa dyan mga clause na, for example, yung patient lives in a far-flung area with no access to medical care, pwede mo rin sila cholecystectomy if meron silang gallstone disease. But again, sabi nga natin, these are controversial now and hindi na siya masyadong ina-advocate. The usual stand natin ngayon is we do cholecystectomy for patients that are symptomatic or those with high risk for gallbladder cancer. So we're done with cholecystolithiasis. We're now moving with cholecystitis. So itis, di ba? It denotes inflammation. So merong inflammation na nangyayari within your gallbladder that would cause you signs and symptoms like right upper quadrant pain, fever, and then your Murphy's sign. So what happens when you have cholecystitis? So ang start point lagi niyan is of course you have to have gallstones. Na-discuss na natin ito kanina. It would cause transient obstruction, causing the biliary colic, and then magkakaroon ka ng inflammation. If the obstruction is relieved or nag-reverse on its own, it would only entail minimal histological changes na it would lead also to your chronic cholecystitis. But if the obstruction or hindi bumalik yung stone doon sa lumen, it's not relieved, okay? Inflammation can lead to edema, eventually mamaga siya, magkakaroon ng vascular compromise, so magiging necrotic yung area na yun, and it could lead to perforation. Okay, so yun yung spectrum ng cholecystitis. And ito yung, if you look at this point, ito na yung complications of cholecystitis. Ito na yung mga pathophysiology nun, ng necrosis and then your perforation. So going back, cholecystitis, okay, ito yung risk factor, fat female 40, and this is Eddie Murphy. Okay, because Eddie Murphy or the Murphy sign, ito usually is a cessation of inspiration while palpating under the right costal rib here or the right upper quadrant area. That's the Murphy sign. It's the arrest in inspiration. So when ask the patient to inspire, and then do deep palpation dito, okay, pag nag-arrest you or tumigil na yung paghinga niya, transiently, it is a positive Murphy sign. Ibig sabihin kasi nape-press on mo yung Murphy, yung gallbladder ng patient, kaya i-arrest niya yung paghinga niya, or hindi niya lalaliman lalo, para hindi mo malaliman din yung pagpalpate, hindi mo ma-press on yung gallbladder niya. Okay, in terms of cholecystitis, marami yung guidelines on how you would diagnose it or how you would document the diagnosis. But ako personally, what I prefer and what is practical, I think, is the Tokyo guidelines. Tokyo guidelines, you would hear it as TG. TG13, TG18, when you remove the term, they are referring to Tokyo guidelines. So dito, gusto ko siya because it's systemic and then mas madali siyang i-memorize. So basically, it's composed of 3 conditions lang. Local signs of inflammation. Kailangan may inflammation talaga. Cholecystitis nga eh. Diba? And then, it can be both local and then it could be systemic also. And meron ka dapat imaging finding to diagnosis. In terms of local signs, pwede yung Murphy's sign and then right upper quadrant mass, pain or tenderness. Meron kang systemic inflammation like your fever, okay, elevated CRP or C-reactive protein, and leukocytosis or elevated WBC. And then meron kang imaging findings characteristic of acute colic. Kapag meron kang 1 item in A, saka 1 item in B, suspect mo na yan. Okay, kumbaga history and TE pa lang, suspect mo na kung cholecystitis siya. Ang kailangan mo lang idagdag is proof na talagang maga si gallbladder mo. And i-clench mo yan using imaging. Imaging via an ultrasound and via a CT scan pwede. So ano ba itong imaging findings characteristic of acute cholecystitis? A plus B, suspected. Dagdagan mo siya ng 1 item sa A, 1 item sa B, saka evidence on ultrasound, sure na cholecystitis yung condition. So this is an ultrasound of a patient with cholecystitis. So yung mga, of course, cholecystitis, ang first requirement mo, dapat mo visualize ka na gallbladder stone. So ano pa? Gallbladder enlargement or malaki yung gallbladder. Diba? Tandaan nyo lang inflammation, dolor, color, rubor, dolor. Diba? So malaki, enlargement. Gallbladder wall thickening, parang may edema na siya, kaya makapal na siya. Pericholecystic fluid collection, meron ng tubig around the gallbladder. May gas, may debris, and meron tayong tinatawag na sonographic Murphy's. Ibig sabihin yung sonologist mo muna, mismo yung gagawa ng Murphy's sign under ultrasound guidance. Kasi makikita niya na yan, using the transducer, itatry niyang i-compress yung gallbladder. Okay? Ipipress niya, mag-move down to, tapos makikita niya mag-arrest yung inspiration ng patient as he or she presses down the transducer. Para nga naman, hindi madaganan lalo or makompress lalo yung gallbladder. Okay? Because that compression leads to pain. I'm sure in your discussion sa med school, you have heard of the term HIDA scan. Okay, HIDA scan is a nuclear test. It's a hepatic immunodoacetic acid scan. So it's a nuclear tracer that they inject intravenously. It will be taken upon by the hepatocytes and eventually, ang ideal, i-excrete siya dapat into the biliary system. Now, it would be helpful in excluding acute cholecystitis. Again, because of cystitis or it's because of the inflammation, it's sort of the biliary system will be obstructed. Dahil maga nga siya, okay, hindi makakalabas yung nuclear tracer mo. So what is a positive test for HIDA scan? Ito yung normal ng HIDA scan. When you inject a dye, dapat within 60 minutes, okay, yung dye mo would fill the biliary system already. Kaya ma-visualize mo siyang ganyan. This is the gallbladder, this is the cystic duct, this is the common bile duct, this is the hepatic duct. Meaning the nuclear tracer is already in the biliary system. But in terms of cholecystitis, because of again the edema and inflammation obstructed yung system mo, therefore yung nuclear tracer mo would not be excreted or will not accumulate within the biliary system. All right? So you have a diagnosis already. What's more important is you know or how to counsel them in terms of their management. So as part also of the Tokyo guidelines, it has presented a spectrum from grade 1 to grade 3, grade 3 being the most severe clinical presentation of patient with gallstone disease. So the spectrum siya, start tayo sa pinakamadulo. Yung grade 3 ay yung pinakamalala or those patients that are high risk for surgery. Ibig sabihin, compounded na yung problem nila. Other than the gallstone disease, ito yung mga may multi-organ failure, those in shock, those with unstable comorbids, or baseline, sila yung mga poor surgical risk or the risk of the anesthesia, the procedure alone would give them poor prognosis. So yun yung mga toxic na patients, grade 3 yan. Grade 1, ito yung mga mild conditions. Ibig sabihin, yes, they have gallstone disease, they have biliary colic, and relatively early pa yung presentation nila. Ang cut-off natin dito usually within 72 hours from the onset of signs and symptoms, good risk or they would benefit from an earlier outright cholecystectomy. So huwag mo na silang pauwiin sa ER. If they're amenable, okay, mag-benefit sila in the long run if you do the surgery right away. Yung grade 2, ito yung gray area in the middle. So ito yung mga patients natin na pwede namang good surgical risk with stable comorbids, but meron silang mga findings of local or severe inflammatory conditions like yung mga may abscess, merong mga edema na within the gallbladder that could surgically be more challenging. Kumbaga, since magana siya, pwedeng dikit-dikit, okay, mas mahirap operahan yung patients. So yung options nila would include the options for grade 1 and grade 3. Yung drainage lang or putting a tube to divert or to drain the bile temporarily, or pwede naman silang i-outright mo naman ng cholecystectomy. Usually, ang cut-off naman dito is the 96th hour of presentation. Or kung mag-present sila early on within the 96 hours, kung gusto mo siyang operahan mo na siya within that time frame. So we're done with cholecystitis. We're moving forward with cholelithiasis. Cholidocco, what it's referring to now is the common bile duct. And if you would see, I highlighted here na usually yung patients with cholelithiasis are presenting naman with jaundice. Cholelithiasis, it can be primary or secondary. Primary meaning the stone is actually formed from the common bile duct na mismo. Whereas pag sinabi mo secondary, the gallbladder stone, nalaglag lang or nag-migrate lang siya to lodge within your common bile duct. Yung secondary, siya yung most common or yung nalaglagan lang ng bato. Okay? So yan, then of course, after naman, may mga conditions tayo minsan na cholecystectomy na yung patients, pwede pa rin silang mag-develop ng cholelithiasis. It can be categorized either retained, residual, or recurrent. So, retained, usually naiwan lang, hindi natanggal during the cholecystectomy. Residual, ibig sabihin, kapareho siya nung tinanggal before, naiwan or natira lang. And then recurrent, assume siya na nagkaroon ng bago or nag-develop ng bagong stone yung patient in the CBD. So again, this is the biliary tree rather. So your common bile duct is here, di ba? So this is your common bile duct, this one. Okay, so kapag dyan nag-lodge yung stone, magiging barado yung biliary system mo. That's why their common presentation is jaundice. If you do work out with cholelithiasis, yung presentation niya would be again consistent with the clinical presentation of cholestasis, or ibig sabihin not good flow of your bile. So you would expect leukocytosis, hyperbilirubinemia, elevation in your alphos and GGT, which points everything to obstruction or hindi magandang flow. In ultrasonography or in any imaging, cholelithiasis would give you dilation, or ibig sabihin lumalaki yung common bile duct, diba? Dahil may obstruction, okay, yung sa taas na part ng tree natin, yung mga branches niya would be dilated because the bile would accumulate there. In terms of gaano ka-dilated ang dilated, ito yung common point of debate amongst hospitals, surgeons, kasi different textbooks will give you different cutoffs as well as different guidelines. And then meron pa din yung mga institutional or iba-ibang institutions would give different cutoffs, iba for Filipinos, iba for Americans, iba for Australians. But for our purposes, the most widely accepted cutoff is a 6mm cutoff. So what does the cutoff mean? So if you have a patient na 6 cm or more yung diameter of the CBD, meron siyang 28% chance, okay, na yung obstruction na yun is caused by a common bile duct stone. Come to think of it, hindi naman ganun kataas yung probability, diba? 28%. But it's enough suspicion for you na kapag dilated yung common bile duct mo, chances are 28% it's because of a common bile duct stone. Okay? And then the next point of discussion lagi dito is when to use MRCP and when to use ERCP. In med school, our teachers always emphasize to us that ERCP is preferred. Tama naman talaga sila because it has the benefit of being both diagnostic and therapeutic. But let's not forget that ERCP is a procedure. It's not a completely safe procedure. Your patient will have to be anesthetized. Of course, there are procedural complications and risks associated with ERCP. So again, dito na papasok yung clinical judgment noong doctor or your attending. So, kailan ka magpapa-MRCP, kailan ka didiretso na ERCP. So, yun tinatawag natin high risk for choledocholithiasis. Or ibig sabihin, kailan na yung chance na mag-intervene ka din naman eventually dahil meron siyang common bile duct stone. Of course, kapag nakita na may common bile duct stone on any imaging, huwag ka na mag-MRCP, dumiretso ka na sa ERCP. You will able to document the stone again, and then you will be able to intervene right then and there. Ngayon, in terms of acute cholangitis or magkaroon ng malalang infection within your biliary system, again, chances are it is because of an obstructing or infected CBD stone. So, infection siya. So, ano yung management ulit ng infection? It's source control. So, magbe-benefit again yung patient with doing an outright ERCP because you will be able to relieve the obstruction, okay, magpo-flow na yung infected na bile, makokontrol mo na yung infection. So, again, points towards benefits of ERCP. Yan. And if meron kang biochemical signs of obstruction like elevated TBL, mas dilated naman talaga yung CBD mo, again, chances are meron siyang CBD stone. So you would eventually intervene din naman nonetheless. So pag-isahin mo na. Okay? Dumiretso ka ng ERCP if you have the presence of those 3 conditions. But if anything short than that, or ibig sabihin hindi ka ganun ka-convinced na common bile duct stone yung nagkakos ng obstruction, that's where MRCP would come in. MRCP, relatively non-invasive siya na test compared to your ERCP, could support your clinical suspicion kung doon nga ba talaga yung pathology. Okay? So doon makakatulong si MRCP kapag yung patients mo nasa gray zones or nasa indeterminate areas. Also, it's worth noting lang that you have what we call Medici syndrome. So with Medici syndrome, meron kang gallstone in the cystic duct or cystic neck, okay, na nag-impinge doon sa common bile duct mo. Okay, so ang presentation nito, technically hindi siya choledocholithiasis. Nasa gallbladder pa rin yung stone mo. So hindi siya choledocholithiasis. But its presentation would be the same as your choledocholithiasis kasi ang endpoint din naman dyan ay barado rin naman talaga si common bile duct mo. But the management can be different, di ba? Kasi dito, technically, if you remove the cystic duct or the neck, relieve na yung obstruction mo. Di ba? So we're going with the last one, which is cholangitis. Ito na yung infection na talaga, or full-blown infection na of your common bile duct. Cystitis, inflammation lang eh. Ito, cholangitis, inflammation because of an infection. So dito na papasok yung Charcot's triad and Raynaud's pentan. Charcot's triad yung fever chills, upper quadrant pain, and jaundice. If yung patient mo meron ng shock and altered mental status, it becomes your Raynaud's pentan. Ito yung diagnostic criteria by TG18. Nakita nyo na ito kanina cholecystitis, ngayon naman by cholangitis. So kanina diba local and systemic, dito ang kailangan mong i-document naman what is systemic signs of inflammation, fever, inflammatory response. But dito yung na iba, kailangan magkaroon ka ng documentation na mayroong cholestasis. So example niya, would be clinical jaundice and abnormal liver function test. And then yung last part natin, would be parang yung kanina din, imaging. Diba? So mas madali ko siyang na-memorize. So one item in A, and then one item in either B or C could give you a suspected diagnosis. One item in A, one item in B, and one item in C, definite diagnosis yan of cholangitis. So parang cholecystitis kanina, yung management of cholangitis can be from grade 1 to grade 3. Okay? Ganun na naman tayo. Si 3 siya naman yung pinakamalala. Siya na naman yung toxic na patient mo. So usually kapag isa pinakamalala na patient, ang goal mo doon would be of course address yung reason kung bakit siya naging toxic in the first place, kung yung mga organ failure, yun yung i-address mo. And then dito magkakaroon ka lang ng biliary drainage. So tulad din ng kanina sa cholecystitis, hindi yung mga options mo. Okay? Pwede kang magkaroon ng percutaneous drainage or magko-cholecystostomy ka doon na, or pwede kong maglaparotomy or maglagay din ng tube or decompress mo lang yung common bile duct mo. And of course, pwede ka mag-ERCP with papillotomy. But sabi ko nga, easier said than done because usually yung ganyang patient, poor surgical risk or poor anesthetic risk na rin sila. Yung grade 1 naman, madali lang ang management. Conservative lang tayo. Or usually, because if it's an infection would warrant antibiotic administration, and likely yung kanila would resolve after appropriate antibiotic therapy. Okay. This slide is parang overview ko lang of the management of the 4 conditions that we have discussed. Pag cholelithiasis or cholecystolithiasis rather, if symptomatic, you do laparoscopic cholecystectomy. If cholecystitis, if meron kang inflammation, laparoscopic cholecystectomy na yan for sure. Okay, yung timing na lang yung magkakaiba-iba. Pag choledocholithiasis, your options, of course, tanggalin yung barado. Okay, ang isang option dyan would be to do ERCP, or isang option pa rin is to do open cholecystectomy with CBD or your common bile duct exploration. Kumbaga sabay na. You go into surgery with the intention of removing the obstruction na open technique, usually right upper quadrant incision, but since you're there already, kasama mo na kung saan man nanggaling yung gallstone na yan, or diba sabi natin more common yung nalaglang na bato. Therefore, you have to remove the gallbladder also. So open cholecystectomy with CBDE. Yung cholangitis, if ideal in your setting and kayang mo yung patient, ERCP is preferred. But if hindi, other options would include percutaneous drainage. On the next slide, I'd like to reiterate lang to kasi common question to, especially for clerks and interns pa nag-assist kayo sa OR. Tinatawag natin Tallo's triangle, the triangle of Tallo. The borders being your cystic duct, your liver edge, and then your common hepatic duct, because contained within this triangle is your cystic artery na kailangan mag-clip siya during your cholecystectomy. So make sure you know this border, the borders of your triangle of Tallo, because chances are pa nag-assist kayo with cholecystectomy, be it either open or laparoscopic, kinakatanong sa inyo ng inyong attending physician. Alright? So, kayo na pa ako ERCP ng ERCP. Akala naman pala lost na kayo what ERCP is. So for those who hindi pa nakakapag-observe ng ERCP, this is how it goes. You put in a scope, the patient is under anesthesia, you put in a scope plans already or doon sa bibig niya. It's a flexible scope and ang goal mo doon ay ma-lodge or makita ito, yung ampulla of Vater. So with the ampulla of Vater, under direct visualization, you would try to cannulate the ampulla of Vater, mag-inject ka ng contrast or ng dye, tapos pwede ka na mag-manipulate dyan, pwede ka maglagay ng stent, pwede kang gumamit ng basket para hatakin yung bato na nagbabara from your common bile duct. So, more associated pathologies of the gallbladder. Okay, gallbladder polyps, na-discuss na natin yan kanina. Gallstone disease, tapos na rin tayo dyan. And then last now would be gallbladder malignancies. So, gallbladder carcinoma, it is relatively rare, usually affects the elder population, more common among women. And then, with the risk factors, for example, nga, large stone disease, nasabi natin yan kanina, more than 3 centimeters, polyps of greater than 1 centimeter, porcelain gallbladder. Okay, and exposure to chemicals like azotoluene and nitrosamines. And common histopath of gallbladder carcinoma is an adenocarcinoma. And usually, at the time of diagnosis, yung patient na to, 40% already have distant metastasis, making it na magkaroon ng poor prognosis. Ang presentation ng gallbladder carcinoma, usually similar siya with any gallstone disease. And usually, kadamihan lang din sila, gallbladder carcinoma is a diagnosis doon sa post-cholecystectomy specimen. Or kadalasan, incidental finding sila sa cholecystectomy specimen. Okay? And dahil nga most of them are metastatic, usually at the time of clinical presentation, mostly palliative na yung treatment natin sa kanila. For bile duct carcinoma, it's again a rare tumor. Again, na-discuss natin ito kanina, di ba, sa cholangiocarcinoma. Mostly involves the hepatic duct and its bifurcation. So 95% ito, ang most common type would be adenocarcinoma. It could be intrahepatic or extrahepatic, tuloy na pag-usapan natin. And if it occurs within the bifurcation, yung tinatawag natin na Klatskin's tumor. For bile duct carcinoma, presentation niya parang obstruction na naman. Alright? So painless jaundice and then constitutional signs and symptoms of malignancy. We have also discussed previously that yung pinagsama na CA19-9 and CA can support the diagnosis of cholangiocarcinoma. For the treatment of bile duct carcinoma, if unresectable, okay, or hindi mo talaga kayang tanggalin because medyo mataas yung magiging point of obstruction mo dyan, you can do tawag doon, diversion or percutaneous drainage techniques. So ang isang option natin dyan, yung discuss yung hepatico-jejunostomy, meaning you take out the confluence kung saan sila nagbabara, and then you attach a portion of your jejunum para doon mag-drain yung bile natin. So tingnan yung image, mga magic tayo, okay, tingnan yung portion na nawala, yung natanggal would be the left lobe, okay, kung yung tumor mo ay left-sided, damay yung buong left side of your liver, and then you would remove the common hepatic duct and you would attach the remaining right hepatic duct to a jejunal segment, yung tinatawag na hepatico-jejunostomy. So we're done with the pathologies of the gallbladder. Tapos tayo tatlo na yan. So we're moving with the pancreas. With the pancreas, tatlong conditions lang tayo dito. Pancreatitis, be it acute or chronic, and then meron tayong pancreatic adenocarcinoma. For acute pancreatitis, ang pathophysiology nito would be autodigestion of the pancreas by the pancreatic enzymes. Commonly associated siya with alcohol abuse and gallstone disease. So ang pain nito is severe, constant epigastric pain relating to the back, and yung pain mo would be improved if you move forward para mawala yung visceral irritation from the pancreas. Okay? So dito, how do you diagnose the acute pancreatitis? We can use what the Atlanta criteria for that. So 2 or more of these 3, madali lang tandaan, would clinch the diagnosis of acute pancreatitis. Abdominal pain, kaya kapunta sa ear mo yan, nag-abdominal pain ng patient. And then amylase and lipase, more than 3 times of the upper limit. Okay? Pero lagi nilang tanong, favorite na question dyan, ano naman specific for pancreatitis? And the answer to that is, kung papiliin ka ng isang test lang, amylase or lipase, the answer to that is, of course, lipase. Okay? And yung characteristic imaging of findings, we will discuss it later, na pag may nakita problema by imaging doon sa pancreas or may changes, nabubulok, namamaga, dilated or barado, malamang doon yung problem mo, di ba? Pancreas talaga. Acute pancreatitis, meron din tayong mga signs and symptoms related to that. Meron tayong tawag na Gray Turner and Cullen sign. O si Dr. Gray turning. Okay, so yan, siya yung nasa flank. Pag nagkaroon ka ng discoloration on the flank side or turning left, just as shown in the picture ni Dr. Meredith Gray, yan si Gray Turner sign. Whereas dito sa kabila, si Edward Cullen or the Cullen sign, if nagkaroon ka ng bluish discoloration in the center or sa may periumbilical area, that relates to acute pancreatitis. So dito, also with Atlanta classification to, parang yung cholecystitis kanina, grade 1 to 3 naman siya. Pero siya, severe, moderate, and mild yung tawag sa kanila. Pag severe, parang yung kanina din, multi-organ yung failure. Okay, pag moderate, ito yung mga acute kidney injury lang or mga reversible yung organ failure na napapakita. Usually mag-resolve within the 48-hour period. Yung mild, ito yung absence of organ failure and or local system or complications. Ang maganda dito, by exclusion ang gagawin niyo. If yung patient nyo presenting with the characteristic abdominal pain of the patient, okay, elevated ang amylase or lipase, tapos may mga diagnostic finding like this one sa imaging, acute pancreatic fluid collection, pancreatic pseudocyst, may acute necrotic collection, and wall of necrosis, okay, mild yan papasok. Diba? 2 of 3 of those, mild papasok yon. Pag nagkaroon ng organ failure, tapos sabi mo ay reversible naman yung liver, yung failure, organ failure niya, moderate lang yan. If nag-persist, nag-develop or lumalak, magpo-progress siya to severe. Alright? Yun yung pinasimplify. Kasi by history, we use what we call the Ranson prognostic sign. So you use this not to diagnose pancreatitis, but rather to classify them or to prognosticate them. So yan, yung mga parameters, your age, WBC count, FBS, LDH, and SGOT, you take it upon admission, and then kapag your Ranson signs mo is less than 3, mild disease lang yan. If 3 or more, severe na yung sakit. Okay? But sabi ko nga, in the clinics, at least from my experience, yung Atlanta or yung mild, moderate, severe, yung mas ginagamit na ngayon. Ang maganda lang kasi with Ranson's prognostic scoring, it would tell you about the associated mortality of pancreatitis. If mag-positive siya for more than 7 signs, okay, almost 50-50 yung patient, more critical yung patient mo. So it would help you in prognosticating your relative as well as how aggressive you would be with the management. With acute pancreatitis, its management, if you would notice, is partly, or makaramihan yan actually medical. But acute pancreatitis, chances are marirefer siya sa inyo kasi sa surgery kasi yung abdominal pain yan would be very, very, very severe. And you as a surgeon should be on the lookout always kung kailan magiging surgical na yung acute pancreatitis. For example, may signs na of necrosis on imaging. Despite antibiotic treatment and conservative management, hindi naging improving patient, you would support with surgical debridement or surgical management to relieve the obstruction. So kumbaga dito, pwede ka siya mag-progress to surgical condition anytime. Kaya laging nire-refer ang pancreatitis also to surgery for co-management. But look at this, the foundations of managing acute pancreatitis, parang medical siya nagsa-start, di ba? Analgesia, nutritional support, antibiotic, and ERCP kung kailangan. In terms of progressive pancreatitis, ito, progressive siya, hindi siya one-time, big time. Inflammatory disorder causing irreversible destruction to both exocrine and endocrine tissue of the pancreas, most commonly associated with alcoholism or alcohol use. Dito, compare and contrast lang natin sa acute versus chronic. Acute pancreatitis, how do you diagnose? Sabihin natin 2 of 3 ng Atlanta criteria. Whereas kapag chronic pancreatitis, amylase and lipase may not be elevated. Moving on with pancreatic cancer, I'm sure you're familiar with this one, common to the news, and we have prominent personalities who have this. So, ang pancreatic cancer, diba, as you all know, the pancreas has exocrine and endocrine functions. So, yung exocrine part niya, kapag doon nanggaling yung malignancy, we call it pancreatic cancer. So, 2/3 of which occurs in the head of the pancreas. Kaya yung presentation niya, diba, para din siyang gallstone disease. Because nag-merge siya with the common bile duct, diba? So, yung presentation niya, palpable mass, palpable gallbladder, tapos may associated jaundice kasi other than the pancreas, barado din yung biliary system mo. And usually, parang yung gallbladder cancer, at the time of diagnosis, usually poor na yung prognosis and it is usually highly lethal. Kung ang polycystitis, may Murphy's sign. Ang pancreatitis, may Great Turner and may Cullen sign. Ang pancreatic CA, meron din yan. Diba? Sabi natin ang constellation niya, non-palpable, non-tender, palpable gallbladder and jaundice. So other than that, yung isa pa, medyo high yield for the boards and exam purposes, yung tawag natin COVA-CA. Diba? COVA-CA sign. So again, palpable, non-tender gallbladder. And then yung Trousseau sign or migratory thrombophlebitis. Pag nakita mo din yung dalawa na yan, suspect pancreatic cancer. And for the interns out there, I think dapat i-goal ninyo na in your experience, dapat maka-assist kayo with a Whipple's procedure. Ito yung common na kung naghahanap sa TV drama ng mahirap na surgery or matagal na surgery, ito yung ginagamit nila. Okay? So what is a Whipple's procedure? So ang goal mo dito would be to remove the pancreatic head tumor. But usually, hindi mo kayang tanggalin na yun lang ang kasama. When you do a Whipple's procedure, kadalasan nasasama yung duodenum. Because if you would remember your anatomy, your pancreatic head is closely related to the duodenum. Tapos na duodenum din sa D2, doon nagde-drain yung common bile duct natin. And yung pancreatic duct, nagjo-join siya in the ampulla of Vater. And then the ampulla of Vater opens to your duodenum. So kapag tinanggal mo yan, ito yung buong segment na matatanggal. Yan, pancreatic head as well as your duodenum. So putol na yung mga communication yan. So kailangan mo siyang reconstruct. Saan mo ididikit ngayon yung mga naputol? First, you will do cholecystectomy. You would attach the common bile duct or your common hepatic duct to a portion of the jejunum. Next is yung pancreatic duct. Iko-connect mo din siya to a section of the jejunum. And then dahil wala na ngayong duodenum, okay, i-bypass mo na yun or iko-connect mo na ngayon si stomach, iko-connect mo na siya directly to the jejunum. So ito yung ending ng reconstruction natin. Okay? And more than doon sa actual resections mo, you also have to do a cholecystectomy and trunk valvotomy. Valvotomy para makontrol yung secretions, and then cholecystectomy dahil yun, damay na rin siya in close relationship siya with your common bile duct. So dito, pancreatic cancer, when you have a patient with pancreatic CA, as a surgeon, ang goal mo lagi is to assess for resectability. Okay, yun dapat yung laging step 1 mo, kaya ko bang tanggalin yung bukol? Because yun yung best chance of patient mo of having better survival if you're able to remove the tumor. Not only did you decrease the load of the burden of the tumor, pero yung mga diversions or yung mga possible problem niya in terms of obstruction, ma-address mo din siya early on. But yun nga, kapag head, you will do a Whipple's procedure. 2/3 nasa head, diba? But if yung tumor nasa body or tail, near or total pancreatectomy yung kailangan gawin mo siya. Distal near total pancreatectomy. Relatively, if isipin nyo, baka mas madali yung surgery kung body or tail siya. Kasi wala ka ng mga reconstruction na kailangan gawin kasi hindi mo mababiolate yung drainage ng pancreatic duct at ng common bile duct sa duodenum. So that alone saves you 6 to 8 hours siguro of surgery. And if unresectable yung tumor, of course, mga palliative procedures yung gagawin dyan. Of course, kailangan makakain yung patient mo, di ba? Para hindi bumagsak yung nutrition. So yung mga options na i-consider mo dyan, pwede pa rin siya mag-gastro-J or gastrojejunostomy or pwedeng outright lang na feeding jejunostomy, or of course palliative chemo can be offered to the patient. Helpfully, ma-decrease yung size niya, ma-relieve yung obstruction. Kung biliary system ang nagbabara dahil again in relationship yung tumor with the ampulla of Vater, so pwede ka mag-percutaneous drainage or lagyan ng tube sa tiyan yung patient para yung bile niya may lalabasan pa din through a catheter. Alright, so that's the end of GS3. We have discussed the liver, the gallbladder, and the pancreas. To wrap things off, okay, with Genesis surgery, or I think how you should tackle surgery as a subject during your Genesis program, I like to share a quote I got when I was a clerk. Our consultant told us that if you hear hoofbeats, think of horses and not zebras. So if you hear hoofing sounds, diba, especially if you're in the Philippine setting, okay, chances are the one causing it are horses. Unless sa safari ka siguro, okay, that's the time you would consider zebras. So that's what we're trying to teach you now, the horses. Okay, kung ano yung mga horses na yan, or yung mga common conditions that could explain the clinical presentation of your patient. And then yung mga zebras na yan, i-add on yun na lang yan as you go on with your training or your surgical experience or your clinical experience, diba? As you build your clinical library na tinatawag natin. But again, sabi ko nga, do not fall to that mistake in trying to memorize everything because I think mahirap talaga siyang gawin. So let's start with the basics first and eventually together, alamin natin yung mga zebras na yan. Okay? So again, I end my lecture. Again, I'm Dr. Esperas. Flashed in your screen is my contact information rather in true top-notch fashion. Okay, do not hesitate to ask us questions through Doc Broly or directly to me and we'll answer it the soonest time possible that we have. Okay? Bye-bye. Trauma, as defined as WHO, a cellular disruption caused by an exchange of environmental energy that is beyond the body's resilience, which is compounded by cell death due to ischemia or reperfusion. That's very technical, diba? But basically, trauma is any external force applied on the human body that is beyond its capability to resist that force. Okay? For this top-notch Genesis surgery, it will be different from your other GS1, GS2, or GS3 lectures because trauma, para itong novel with multiple endings, a lot of scenarios, a lot of probabilities. So instead of going through with the specifics, what we want you to grasp with this lecture is the mindset or the approach on how to tackle patients trauma. Okay, that's kumbaga the bird's eye view of how you are expected to function in the emergency room setting, diba? Kumbaga there's no way to prepare you for it. But kung paano kayo your demeanor and your approach to the ER, yun yung gusto namin gawin sa inyo. In PGH, we have a term that we call na SOL or space occupying lesions. And hopefully with top-notch surgery program, hindi kayo maging SOL or space occupying lesions lang in the ER when you go through your rotations. Okay, dapat mas magiging productive na kayo in hemothorax. Ang difference lang dito,